Greetings, I am Kritika Saxena. I am a clinical psychologist. Today we would be talking about the treatment interventions for anxiety disorders. Let us quickly just recap what were the anxiety disorders that the DSM-5 has laid out. There is selective mutism, separation anxiety, panic attack, agoraphobia, generalized anxiety disorder, which is the most common. Let's understand that what does the treatment intervention mean here. The first line of treatment intervention is that of psychiatric medication. A psychiatric medication should only and only been diagnosed and prescribed by a psychiatrist. A psychiatrist is a doctor who has pursued their MBBS and their MD and they qualify as a psychiatrist. Please understand that nobody else other than a psychiatrist should be prescribing any psychiatric medication, since those are the people who are experts in this field. Now, psychiatric medication, it's not one dose fits all. Just like how one would have a headache and I would take one medication whereas another individual would take another medication. So the key point to note here is that different medications, different types of molecules in those medications suit different individuals. A lot of time there are myths that this medication would not suit me or it did not suit me and hence the entire psychiatric medication would not suit me. Sometimes one medication, one molecule might not suit us, but maybe the other one does. And that is where we need to go back to our psychiatrist and discuss more intervention plans, more medications with them. Whenever the medications are first started, they started on a low dosage, keeping in mind the symptoms or the severity of symptoms that the patient or the client has shared with that psychiatrist. And slowly and gradually that medication is modulated and brought up in doses till the time that it peaks and then there is a plateau. That plateau is called the maintenance. That is where the same amount of dosage is giving us the kind of result, is giving us the comfort from the discomfort of the symptoms, and that continues for anywhere from 6 months to 1 year. That is the best that your psychiatrist will judge. And later, whenever the psychiatrist feels that the medication is giving us the kind of results that we want, and maybe now it is time to taper them off, they do so. Oftentimes you'll hear the myth that psychiatric medications once started will never be ended and you would have to take them lifelong. That is not true. It might be true in certain diagnoses such as schizophrenia, such as bipolar, but not for all disorders and not for all medications. One needs to take them a lifetime. This is something that you go back and forth with your psychiatrist, discuss the medications, discuss the plan, discuss the amping up the dosage and the tapering of the dosage. So medication helps target the neurotransmitters that are there in our mind and the imbalance that they have caused due to which we are experiencing these symptoms. Remember, we spoke about the causal factors and we spoke about how neurotransmitters such as GABA, serotonin, they become in imbalance and that is what causes these symptoms. So the medication, which is also a chemical, goes and fixes that imbalance. In order to fix those neurotransmitters, those neurochemicals, the medications are required. And depending upon the severity of the symptoms, the dosage is altered. Coming to the next intervention, which is your relaxation techniques. There are various relaxation techniques, grounding techniques that also we talk about. One of them is JPMR, which is Jacobson's Progressive Muscle Relaxation. Jacobson, who was a professional clinician, had given this relaxation technique. From your head to toe, you stretch and flex, and let loose of each muscle, trying to let go of the tenseness or the stress in each muscle. Grounding. The grounding technique, which is practiced mostly, is that of your five senses, which is 5 things to see, 4 things to hear, 3 things to touch, 2 things to smell, and 1 thing to taste. How these relaxation techniques help us is that they bring the focus more onto our body, more onto our physiology, and try to relax the body, the soma, or the physiological symptoms. Once that happens, then the intervention can move to the next stage, which is that of cognitive restructuring. Cognitive restructuring, as the word suggests, it's about restructuring our thoughts. Cognitions are our thoughts. Remember, in history taking, we spoke about that how there are a lot of negative thoughts associated with each disorder, where the client or the individual might anticipate that something wrong is about to happen, this would happen, that would happen. Now those negative thoughts, they need to be restructured. How does this restructuring happen? Is by looking for evidence, which is evidence seeking, is by giving logic or facts to the negative thoughts, is by rationalizing, which is finding meaning behind that. Cognitive restructuring is a part of cognitive behavior therapy, which is also a therapy which is highly recommended for anxiety disorders. So cognitive restructuring is only a small part of that. Another technique or another intervention for anxiety disorders is exposure, or rather exposure and response prevention. Now, as the word suggests, the individual is exposed to all those situations that create that anxiety, fear, distress, discomfort. And the response that they usually have, which is of fear or anxiety, we try to prevent that. That can be done through modeling behavior. Maybe the therapist or the clinician, they themselves can do it first, show the client that, see, this is how it is done. We don't need to feel anxious here, we don't need to have this fear here. Of course, the component of cognitive restructuring also is playing alongside. But exposure is mostly about the behavior modification which is being done. So you expose yourself to that specific situation, suppose let's say that of elevators, of that of heights. You try to rationalize your thought, the cognitive restructuring which happens, and you still go ahead and do that activity rather than what your original response was, which was of avoidance or withdrawal from that situation. Another intervention is that of problem solving, which is a problem is presented to you, and rather than spiraling in that problem, the thoughts which tend to multiply, one anxious thought after the other, you take a pause, you hit the brakes, and you ask yourself, what would be a solution focused approach here? If there is a problem, then obviously there would also be a solution. So rather than spiraling in those thoughts and only thinking about catastrophic consequences, one takes a pause and looks more towards problem solving. Now let's go into depth. The relaxation technique that we were talking about, they focus on the physiological arousal, which is through deep muscle relaxation, sometimes positive imagery. The clinician or the therapist can have a guided meditation or guided imagery where the client lies down, they're asked to close their eyes, and they're taken through a positive image, a narrative which derives that positive image. There can also be meditation. Something to note here is that meditation is not recommended for all. Sometimes meditation, which is sitting by yourself, closing your eyes, bringing your focus on yourself, can also be contraindicated depending upon how your thoughts are impacting you. Another form of relaxation training can be deep breathing or box breathing, where you inhale through your nose, hold the breath for a while, and then exhale through your mouth. How this helps is with more oxygenation to the brain. You're taking up more oxygen, you're letting it run throughout your body, and then you're exhaling carbon dioxide. The more time that you take through this, the more oxygenation of the brain that happens and more calm the body becomes. Going back to cognitive restructuring, in cognitive restructuring, we are identifying maladaptive cognitive patterns or thought distortions, as we call it, which is an error in the thought process. We challenge those maladaptive cognitions. By maladaptive here we mean that they are not adapted, they are not helping us in that process. And third, we develop a more adaptive cognition. So identify, challenge and develop a more adaptive cognition. The exposure and response prevention, like we had spoken about, one of the ways was modeling, another is flooding, which is taking the individual to that situation and exposing them and seeing their reaction and holding their hand right there and then, wherein we are flooding the individual with that situation. The confrontation with anxiety or anxiety provoking stimulus. Developing more adaptive internal representations of the stimulus and their non-threatening consequences. Moving on to problem solving training, that what is the problem? What is my goal here? What solutions can I generate to solve the problem? What might be the consequences of each solution? Let me try a solution here. This is particularly prevalent in generalized anxiety disorder because, like we had discussed previously, generalized anxiety disorder is not specific to anything. It is also referred as free floating anxiety. It could be about anything in your day-to-day general life. And when we are not able to find a rational reason behind those negative thoughts that are creating that generalized anxiety, that is where problem solving techniques come in handy the most. Where you try to look for a solution, you try to look for rationality, and if you find that there is no rationality, then you ask yourself how to move on from that situation. This divides problems into manageable units. How can we break them down further? Those were all the treatment techniques for anxiety disorder. Let's sum up anxiety disorder and its treatment once again. Anxiety is a feeling of discomfort and distress that can be caused whether it is to a specific situation or in general. Specifically, it can be selective mutism, social anxiety, agoraphobia, claustrophobia, specific phobia related to animals, heights, other situations, or generalized anxiety disorder. Each and every one of them have different duration, different criteria, but mostly similar symptoms. Symptoms that are there on the physical level or physiological level, such as palpitations, gut wrenching, trembling in your extremities, numbness sometimes in the body, stiffness in the back of your neck, heaviness in chest, difficulty breathing, sweating, mind feeling very clouded, foggy, not feeling oriented, sometimes having dizziness, nausea, vomiting. Those are all physiological symptoms. Some of the cognitive symptoms that define anxiety disorder are anticipating the worst, any catastrophic, which is the highest level where things can go wrong. So, any catastrophic consequences that can be thought of or anticipating that the worst is going to happen. There can also be some other day-to-day life changes that we can see along with anxiety disorder, such as disturbances in sleep, disturbances in appetite, disturbances in mood, disturbances in focus. One is not able to carry out their everyday academic or occupational or social responsibilities as they previously used to. And it can vary from a month to 6 months depending upon the specific disorder that we are trying to talk about. It is very important that while history taking, you focus on the triggers, the duration, the onset, and the symptoms. And most importantly, also how it has impacted the mood. If the severity of the mood symptom is too much, sometimes you may also see that there is a comorbidity with depression, because anxiety and depression, they have a huge comorbid index. A lot of individuals struggling with anxiety may also have depression as their secondary diagnosis, and vice versa. We are also looking at the same neurotransmitters here that cause those symptoms, which is mostly serotonin. Which brings us to the treatment, the synopsis of the treatment, the psychiatric medication which targets these neurotransmitters. It deals with the imbalance of the serotonin. Not every medication works for every individual. One needs to consult with a psychiatrist to find the right molecule, the right dosage, and also the right time period that that medication needs to be taken for. In the therapeutic intervention, there are various interventions. There is CBT, like I had mentioned, which is cognitive and behavior therapy. There is ACT as well, which is acceptance and commitment therapy. There could be relaxation training, which could be deep muscle relaxation, deep breathing, grounding techniques, so on and so forth. There can be problem solving techniques. There can be SFBT, which is solution focused brief therapy model. Now let's take a case study. An individual who walks in to a clinician. What would be the clinical picture like? I once had a client who mentioned that I'm mostly here because I have not been able to sleep for a lot of days. Or when I do sleep, sometimes I wake up in the middle of night with a lot of palpitations or difficulty breathing, racing heartbeat. And I'm not able to figure out why. I somehow try, put myself back to sleep. But then again in the morning, I wake up much early and then I'm not able to go back to sleep. Now I feel because I was not able to sleep, I have a little bit of irritability. Let's say this person is an 18-year-old. They go about their day, they go to their college, they maybe don't feel like interacting with their friend group or the peer group. They are snappy, they are irritable, the friends make a plan to go out for lunch, they feel like not eating food with them. They say they would rather go back home and be there. But the thought of going back home also sometimes tends to give them palpitations. Once they are home and they feel anxiety, they try to lock themselves up in the room and be by themselves. Not talk to anyone, be in that withdrawal, and maybe listen to some music or read or work upon the assignment from their college. Come evening, when the parents ask them to come outside the room, sit with them, have a conversation, maybe have dinner together, they experience these palpitations again and they become snappy and they tell the parents that they would rather eat alone. When they do eat alone, they don't eat much, a lot. Then again the night comes and they are not able to bring themselves to sleep. With the help of music or maybe talking to a friend, they're finally able to put themselves to sleep, and then the cycle starts again with the palpitations in the middle of the night. Now let's recap. What are the chief complaints that we can see here? We clearly see sleep disturbance, we see disturbances in appetite, we see the physiological distress, which is through palpitation, sometimes difficulty breathing. Socially, we see that there is withdrawal and isolation. Mood wise, we see that there is irritability or snappiness which is happening. The follow up questions that you can inquire from this individual is, for how long have they been feeling this way? When did it first start? How did it first start? Let's say the answer to that could be that some 6-7 months ago, my parents, they had a fight and they were talking about divorce, which distressed me. Because then I would not know which parent to go with or to be by myself, because I'm also 18. So that also meets our diagnostic criteria of 6 months. This is your anxiety disorder with all the symptoms meeting the criteria, finding the triggers. What would you plan in this intervention? We see that there is obviously significant socio-occupational functioning impairment which is there, but maybe not to an extent where medication need to be started. Let's start with therapy first. You would like to pick up CBT, which is cognitive and behavior therapy, where you will try to work upon the cognitive restructuring, which is restructuring of the thoughts, trying to find logic and reasons and rationality, trying to change those maladaptive cognitions and replace it with adaptive ones. Here, the core fear that the individual is feeling is that of fear of lack of control. How do you feel that you can try and bring that for them? What can be their locus of control? What can they put in their circle of control? That what is within their reach, what is within their control versus what is not, and how to come to that acceptance and plan or problem solve a way that is going to help them deal with this distress and eventually help them manage their anxiety. That is all. That was a case study from my side. Thank you.